Primary diagnosis is herpes simplex with encephalitis. For primary assessments, neuro would be number 1, immune number 2, GI 3, and pain 4. Neuro would be number 1 because the encephalitis is affecting the brain. We want to check for that level of consciousness, orientation, weakness on either side or maybe on one side as opposed to the other, and slurring of speech. With level of consciousness, we want to check that along with the orientation, weakness, everything. Every neuro assessment, every time, every 4 hours it checks. If anything is wavering from the time before, we're going to want to document those findings. Maybe do some checks a little bit sooner, let the healthcare provider know. Anything here that alters is letting us know that encephalitis is acting back up, which could cause this patient was having seizures, ischemic-like activity, but was negative for actual strokes. But just having that encephalitis, all that pressure in that brain when there's only so much room, anything that changes here, we want to let somebody know right away so we can take care of that. Next is going to be the immune system. This patient's already immunocompromised, so and then went in for surgery as well. So first we want to assess that incision where the PEG tube was. So checking at that first dressing change, we didn't quite get to that yet, but that first dressing change, make sure the PEG tube incision is not red or any green pus coming out. It's going to be a little bit tender, but it's not overly tender. We haven't removed it yet, but if it was looking like that, we would definitely have signs of infection, and we would want to take care of that right away. Watching for those labs. The patient obviously was immunocompromised before, and having a virus like the herpes virus is going to elevate those white blood counts, but we're going to want to watch those to be coming back to normal. Probably not after the first day of surgery, but after that, once everything starts regulating, just making sure they're not elevating even more and not going along with temperature. If the patient's temperature is going up and the white blood counts are also going up, that's something that we maybe need to let the healthcare provider know. That didn't happen with this patient, but if it was, we would maybe want to notify someone, because some of those assessments can be covered up by some of the prior conditions that the patient had. For nutritional diet, the patient is NPO. The patient didn't have the best diet before she came in, but now she's NPO. So we want to make sure with this immunosuppressed person that they're getting, vitamin C, the nutrients that it takes for their body to heal and get better. So, maybe writing a prescription to the healthcare provider or seeing what their thoughts are on that. For GI, first for assessments was making sure the PEG tube drained correctly. All of the healthcare provider had instructions as far as 12 hours of no feedings and just draining. And then we documented all the draining in milliliters, making sure that the color and everything was correct as care provider had stated, and it was. Next, we did assessment was for a bolus feeding. Bolus feeding was done first to see if the patient could tolerate a feeding. Bolus feeding was tolerated, I believe, of 120 milliliters. So we did the bolus feeding. Bolus feeding was tolerated. After the first feeding, we did assess the residual. So we removed the residual out of there, documented the amount, and then we put the residual back in so that the patient can get those nutrients that they need for that immunocompromised body of theirs. Next, assessing the abdomen for after the PEG tube went in to make sure everything is working well. We don't want to have the intervention will be palpating the stomach, making sure there's no hard. Obviously, the patient's in pain, so we want to make sure there's no blockages or anything like that. After palpating, everything felt good, soft with no hardness, so everything was good as far as that goes. For pain assessment, this patient, I did assess once on a scale of 1 to 10 for pain. The patient was at a 3. Per doctor's orders, it was for a headache and it was at a 3, so we were able to administer Tylenol. Headache was relieved at that point in time. At another point in time, we did assess on a scale of 1 to 10. This one was a 6. Pain was in the abdomen. We were able to give a PRN of hydrocodone that the doctor had administered. All these medications were given through the PEG tube. Patient was actually able to rest and get sleep. So, assessing for that abdomen pain again. Came in, the patient was laying on the right side. After multiple checks, patient was in a lot of pain. Intervention, tried to have the patient rotate to the other side. Patient was then able to get some rest. Once again, patient felt relief and actually said she's going to lay on the other side more often because there was so much relief on that left side. And finally, assessing for that midline. Patient is going to be laying on that left side, which is where that midline is, but that's how she gets most relief. So just checking for phlebitis, blockages, making sure she's not pulling on that line, anything like that, redness and swelling, especially since she's immunocompromised. Last time it was checked, it was dry and intact. It had a clear bandage on it, so it was able to see. Risk factors for this patient is she is a smoker. She smokes about 1 pack a day. She has a history of pulmonary embolisms as well. History of immunosuppressant drugs. So that's not helping with, having the white blood count and checking for temperature and everything like that. Patient is already immunocompromised. Patient's also unwilling to receive education. Patient knows what she needs to do, but will not make the changes to do that. As far as complications that can occur, patient can have a decline in neuro at any time due to encephalitis. Checking that level of consciousness, neuro assessments, those are things you all need to be on alert for. So just checking in on the patient. How's it going? You're getting some rest and listening to how they're talking, slurred speech, weakness, facial droops. So at every 4 hours, report change, or any other time you're in there just chit-chatting. Checking that surgical site for infection. So checking for those dressing changes, just taking a quick peek, assessing, making sure everything looks good. So if the patient is, what we're on alert for is if the patient's like, oh, it's just kind of tender when I sit up and it's red, it's hurting, and then you check and it's red and it's kind of greeny. So when you're changing, what we want to do to protect her immunocompromised body is use aseptic technique. And make sure it's always dry. It's not wet, kind of sitting there in its own moisture. The gastric tube, we want to make sure there's no blockage there. Make sure she's tolerating that feeding. We want to be on alert for that to make sure there's no blockages. What we did to prevent that was do a 120 milliliter bolus check, and she tolerated it. And finally, extended discharge is a complication that has already occurred. Patient has a history of anxiety, and definitely has anxiety with this discharge. So maybe you want to do a little bit more education for her on things she can practice. Patient's not getting up and ambulating, so maybe talking about things like that she can do to promote getting better and look forward to when she gets out.